Okay, good afternoon. So again, we are going to discuss regarding delayed breast reconstruction strategies to be discussed. In the morning, we have already discussed the diap flap. Even Hari sir is going to discuss about beyond flaps beyond diap flap. And now the why do we need we'll end up having delayed flap reconstruction. So the indication is basically patients want to complete their adjuvant therapy and they don't want to go ahead for reconstruction in the first setting, because already breast cancer therapy lasts for almost entire year. So it starts with surgery, 6 months of chemo, then 1 or 2 months of radiation, 1 month of radiation therapy. So they want to complete that. That is one part. The other thing is comorbidities, which does not allow longer surgeries. That's why patient land up having no reconstruction. And once they complete, they might go for reconstruction. So by definition, delayed breast reconstruction is basically patient completes her adjuvant therapy and then the reconstruction starts after the adjuvant therapy. So what are the major indications oncologically is the if patient is requiring post mastectomy radiation therapy, or patient is having comorbidities. That's why they choose delayed reconstruction. Now, it's a delayed reconstruction. It's a shared decision making. Patient should be psychologically be ready that now they know that they are surviving through cancer treatment. They have completed their adjuvant therapy. They also must know that the immediate reconstruction would have been always better. It would have given more flexibility to gain volume. So the success parameters also are going to change in delayed reconstruction. So discussion on reconstruction options, risk and benefits should be discussed with patient. Now, what are the options? One is autologous reconstruction. The second is implant-based reconstruction. Third is hybrid method. And fourth is fat grafting, which helps in contouring. So autologous has been very, nowadays it's quite, diap flaps and microvascular flaps have been very successful and easily available in most of the cities now. And pure implant-based reconstruction is very difficult considering the defect, the skin defect and the overlying skin quality after radiation. So I would suggest hybrid techniques like implant with LD flap would give better results. So preferred for if patients are have received radiation therapy, so generally autologous reconstruction are preferred. But in patients like prophylactic mastectomy are done for BRCA 1 or 2 cases where even implant-based reconstruction are favored basically. So the common flaps used is diap flaps, which we discussed in the morning. Latissimus dorsi flap, tram flaps are also done. Tram flaps are also doing well, but only the breast shaping becomes very difficult in tram flaps. Latissimus dorsi flap become very short, fall short in gaining volume. So you can combine with implant to gain volume. Of course, all autologous tissue provide natural feel and appearance and they are preferred choice. So diap flap is gold standard for autologous reconstruction. The main part of diap flap is the skin envelope, the amount of skin which diap flap can give. The entire skin is not utilized all the time to give surface. Most of the skin part is actually utilized to as a volume replacement by deepithelializing the skin flap. So let's assess the defect which is caused in delayed whole breast reconstruction. So there is a larger surgical defect due to tissue changes in the chest wall. It's shrunken because of the radiation therapy. The overlying skin loss is already there as compared to skin sparing mastectomy. In MRM, there is a lot of skin loss over there. So most of the diap flap skin would now be utilized to give cover and not used as a volume replacement. So there is potential also, there is whatever skin is left, there is potential vascularity issues because of radiation therapy, and therefore there is increased risk of complications like infection and poor wound healing. Now, how oncologically safe is delayed reconstruction? So the issue is basically with immediate reconstruction. In delayed reconstruction, most of the patients are completing their adjuvant therapy. So there is no delay in adjuvant therapy from patient's side. So most of them delayed reconstruction are safer. So autologous reconstruction versus implant based reconstruction. Autologous reconstruction again have a greater acceptability in terms of patient related outcome measures as compared to implant based reconstruction. Now radiation and delayed reconstruction is the major issue. Implant failure rates increase with prior radiation therapy. That's why we don't place implants subpectorally and we prepectorally, and we place the implants subpectorally so that we get at least 2 centimeter thick vascularized tissue over the implant. The lower pole is being covered with latissimus dorsi or ADM nowadays. Fat grafting can be utilized as a mitigating component for radiation fibrosis. Now, surgical complications increase in implant-based reconstruction after radiation. So, autologous flaps are being considered more. Again, breast Q and other breast patient-related outcome measures are the major criteria for shared decision-making with the patient. Fat grafting can be used as a hybrid technique and used in most of the radiation-induced scars, such as in anterior axillary fold or breast tail, where we can use fat grafting as an adjunct. Now, the autologous reconstruction has been superior just because it is giving volume, and again crawl scoring again comes into place, where you can also adjust with the contralateral breast, because in delayed breast reconstruction, the contralateral breast is acting as a template where you reconstruct the breast. The initial expenditure on autologous tissue is high, but durability over the period, you can see a long-lasting results in autologous tissue. In implant-based reconstruction, most of the time, most of the implants get extruded, or there are many other complications where you have to replace with the implants, and so autologous is more cost-effective. Again, crawl scoring comes into place, where the delayed breast reconstruction, where opposite breast reconstruction is being considered based on its volume, ptosis, and the entire contour. If it is higher size volume like D or E cup size breast, autologous breast reconstruction with DIAP are the better choice, and can be results can be symmetrical. So DIAP flaps and LD with implants have been the major choices, and secondary procedures like fat grafting can be used as an adjunct. So volume assessment, ptosis grading, and projection matching is what crawl scoring tells us. Now this is an important slide where we categorize patient into low score, moderate score, and high score, depending upon the both breast differences in contour and volume size. So in low score, you only have to reconstruct the same side breast. In moderate score, you have to undergo some kind of mammoplasty on opposite breast. In higher score, there is definite need of contralateral mammoplasty. Now the steps are, the step 1 is basically preoperative assessment of contralateral breast. In step 2, based on the step 1 parameters, you select. If it's a higher cup size breast, you choose autologous. If it is smaller, you can use LD with implant as the choice. In step 3, you can also modify do the contralateral mammoplasty based if you require reduction oncoplasty or augmentation oncoplasty. And step 4 is basically it's a delayed fat grafting so that you achieve symmetry. So nowadays multiple AI softwares have been come. We can actually use crawl scoring, and they can help you with decision making. So there are a few examples. This is delayed breast reconstruction with DIAP flap. This is another delayed breast reconstruction with DIAP flap, where the implant has been removed, and the defect has been filled with DIAP flap. This is delayed immediate breast reconstruction, where you place expander in the mastectomy side, where skin sparing mastectomy is done, and you placed on the right side, you placed implant, silicone implant. Now the expander is deflated before radiation. The patient receives the adjuvant therapy of radiation, and after radiation, you replace the expander with implant. So it is called as delayed immediate breast reconstruction. These are the common scenarios nowadays because of BRCA1 and 2 positive patients who also undergo prophylactic mastectomy on opposite side. So you also use fat grafting procedures. Mostly you can see in the first image. So most of the implant whatever we place, they do not give the superior pole fullness, and many a times there is a furrow which develops because after the radiation. This can be corrected with the fat grafting, and of course you will require multiple sessions of fat grafting to achieve normal contour. Thank you.